Hello, this is Dr. Paul Sachs, and thank you for joining us today. Today, I'm going to talk about managing people with HIV during the COVID-19 pandemic. Recently, CDC and the Department of Health and Human Services have issued guidance about how to think about managing HIV patients with the COVID-19 pandemic ongoing. And I just want to start by emphasizing that the situation is changing very rapidly. I don't have to tell you that, but on a really day by day and week by week basis. So we have to kind of adapt as new information becomes available. In general, though, I think the principle in the CDC guidance is to be listened to, which is that the same practices for preventing acquisition of infection that we apply to people who are HIV negative, we should apply to people who have HIV. We also want to emphasize that people should stay on their antiretrovirals because obviously that keeps their health as best as they can. And then also we should, with our patients, devise a plan. What should you do if in fact you develop symptoms that suggest that you have acquired COVID-19? So CDC guidance goes on further and says that they should have at least a 30-day supply of their medication on hand. I'm going to editorialize and say I think it should be 90, and you'll see that the HHS says 90 if possible. And that's because people who get COVID-19 may need to be self-quarantined for some time. They want to have their vaccinations up to date. I think that's important just in general. I wouldn't say it's critical that they come in for vaccines, but it's very important, especially if you think about it for the next flu season. And then, as I mentioned before, if people need to be self-quarantined at home, are they going to be able to get food? Are they going to be able to get their essentials met? Do they have support systems in place? And if not, can we help them get those in place for them? And then, do you have a telemedicine link? This is something that, there is a silver lining to this terrible pandemic, which is that it has greatly expanded our ability to do telemedicine. And I strongly suggest, if we haven't already done that, that you try to engage in telemedicine as soon as possible. It really is remarkable what can be done. So what about the DHS guidance? Well, one thing they start out by saying is that the limited data so far don't indicate that HIV is a risk factor for more severe disease. And there are all kinds of anecdotes out there about people who are somehow seem to be less sick with COVID-19 who are on HIV meds, or people who are sicker with COVID-19 on HIV meds. And I'm going to tell you that really the data are too new. We don't know yet. We wait really the results of good controlled studies, but already there have been quite a few people with HIV who've acquired COVID-19 and have recovered, including several at our institution, and I'm sure where you work as well. The more important thing is that people with HIV in the United States and globally are getting older. They're getting older because they're so healthy. And as a result, people who are older are at greater risk of severe COVID-19 disease, in particular if they have underlying comorbidities. Now, what about the population of people with HIV who are not on antiretroviral therapy, either because they're newly diagnosed or because they have barriers to taking medications regularly? We do think that they would be at greater risk of more severe COVID-19 disease just because they're immunosuppressed, although again, the data are really limited. Obviously, those individuals, if we can get them into care, get them on antiviral therapy, they're probably more protected from getting severe disease. So if people require hospitalization, what should we do? Well, the symptoms are going to be managed supportively. If possible, they should try to stay home, maintain close contact, and continue their HIV therapy. That's all self-explanatory. That's if you don't require hospitalization. And then I mentioned before about having on hand a supply of medications. Any planned switches in therapy, put them off unless it's absolutely urgent. If someone is stable on their regimen and they're virally suppressed, why go through the difficulties of changing the medication? I do want to emphasize there's a lot of buzz out there about certain antiretroviral agents being active against SARS-CoV-2, but to date, there really is no evidence that any specific antiretroviral strategy should be used in place of any other for management of COVID-19. There was some buzz for a while about lopinavir/ritonavir. The first randomized trial was not encouraging, and I don't think there's a lot of enthusiasm for it anymore. If you have patients who are in opiate replacement programs of some sort, try to make sure that they can continue to receive those medications without treatment interruptions. It'd be very, very unfortunate if we had patients who went through withdrawal and needed to seek medical care for that reason. What about clinical and lab visits? Well, we do a lot of laboratory monitoring of our patients with HIV. In fact, the guidelines say we should do it every 6 months, even in our stable patients. This is one of those times when I think we can actually delay laboratory monitoring. It really doesn't have to be done every 6 months in your stable patients. It can definitely be deferred for a little while. People aren't so suddenly going to get virologic failure if they continue to take their medications. And then last, I do want to mention once again, telephone and virtual visits are an excellent substitution at this time to avoid people having to come into the clinic or come into the hospital unnecessarily. So now I'm going to talk about hospitalization. Definitely continue antiretroviral therapy. People who are critically ill in the ICU, sometimes they can't take oral medications. And if that's the case, you can consult with your ID pharmacist or with your pharmacy group about which medications can be crushed and given via G-tube. There are some that are easier than others. This is also readily available in the DHHS guidance that I mentioned here. The other thing is that if you're uncomfortable in some way in managing patients with HIV who get hospitalized and are in intensive care, by all means, bring in your HIV and ID specialist to help you manage them. There are sometimes antiviral strategies we can tweak that make treatment of HIV in critically ill people easier. So what about drug shortages? I've received this question from several of my patients. Right now, we have not identified any drug shortages for any of the antivirals that are commonly used. I've actually had conversations with some of the major manufacturers of HIV medications, and to date, they do not anticipate any drug shortages. It's being closely monitored by the FDA and other groups because of the issue of the supply chain. The supply chain can be disrupted by a global pandemic. Hardly need to tell you that. So it is something that we're keeping track of, but right now things are going well without any drug shortages for antiretroviral agents. So other issues, well, people in this situation are all under stress. That includes people, even us doctors, even us clinicians. Patients, maybe even more so, and they need additional assistance with things like food, housing, transportation, et cetera. For whatever way we can get access to those programs, let's by all means go forward with them. And then this isolation that we're asking our patients to do can be disruptive to mental health, and engaging help with our mental health professionals to help our patients is a very good idea. So let me just finish up with a quick case study drawn from real life. You can tell because it's an older patient, and older patients for old people like me are very common. This is a 76-year-old man who has long-standing HIV. A former smoker, but not any longer. He has COPD and has undergone stent placement for CAD. He also has diabetes and high blood pressure. He's actually, even though he's in his mid-70s, he's been working full time, but he's not working now because his current job has put him on furlough. Totally stable from the HIV perspective. He's taking 2 pills a day of TAF FTC plus dolutegravir. Never misses doses. His viral load has been less than 50 for more than 10 years, probably more than 20 years. Other medications he takes are losartan, metformin, and metoprolol. And he's just absolutely terrified of coming in for his regular visits because even though he obsessively gets them every 6 months, he just doesn't want to take the chance of coming into a hospital and possibly being exposed to someone with COVID-19. So what are his primary risk factors for severe disease? Well, I would argue that it's not HIV. It would be the fact that he's an older individual, he's in his mid-70s, that he has underlying cardiovascular disease, he has underlying diabetes. These are things that, underlying hypertension, these are things that we know are associated with worse COVID-19. What should you advise him about safety? Well, the same thing we'd advise anyone. Plenty of hand washing, social distancing, avoiding crowds unnecessarily, etc. What about his antivirals? He's currently taking TAF FTC and dolutegravir. Should we make any changes, for example, to lopinavir ritonavir or a better tolerated protease inhibitor just because it might have activity against SARS-CoV-2? The answer is emphatically no. This is not an indication to change medications. What about the other medicines? Like, there's a lot of buzz about ACEs and ARBs. Is this person at risk of getting worse COVID-19 because they're taking losartan? Well, it turns out probably not. There are some observational data suggesting it actually might be protective, and the major bodies like the American Heart Association, et cetera, don't recommend changing any antihypertensive agents based solely on this theoretical concern that upregulation of the ACE2 receptor might worsen COVID-19 disease. And last, does he need to come in for his every 6-month blood test right now in the peak of the COVID-19 epidemic? And the answer is clearly not. We all anticipate that the number of cases will fall. We don't know whether they're going to go away completely, but it will be safer to be in public at some point. We don't know exactly when in the near future, and that is when he should come in and get his blood drawn. Does not need to come in now. So that's a summary of some of the issues and a representative case presentation of the management of COVID-19 for people with HIV. Thank you very much.